there are a few of our friends who have joined now from different parts of the country. So welcome all of you. With me, I also welcome my course co-director as well as 360 Critical Care co-founder, Dr. Sanant Kumar Das from Australia. Hi, Sanant.
Hello, Tapas and everyone.
So with me also, we have the faculties, Dr. Diksha Gaur. Hi, Diksha. Are you there?
Hello, sir.
Good evening. Good evening. So Dr. Diksha is, I would say, the candidate from our previous batch, and she cleared in the first attempt. And believe me, she is my junior from my, I would say, our Dr. Sanand and myself both have studied from Sir Gangaram Hospital. So she is also the alumni from the same hospital from New Delhi, and she is in the final year of the DRNB, which is the super specialty critical care, and she cleared it. So we are very, I would say, happy to have her as the speaker faculty, and she would be describing the questions those were asked to her, and also the answers that were like most appropriate for those questions. So also we have Dr. Nasrina Latif. Dr. Nasrina, are you there?
Hello, sir. Hi, how are you?
Hi, good, good. So Dr. Nasrina is again one of the, I would say, most successful and very appreciated candidate in our last batch, and she also cleared in the first attempt, and she is currently working in UK. And there were like many candidates also, they were benefited from her the suggestions, as well as she also mentored few of our candidate in the last mock exams which we normally conduct in our later part of the preparatory course. So thank you, Dr. Nasrina, for considering our invitation and also joining from UK.
Thank you, sir, for the appreciation.
We have also Dr. Ayaj Akbar. Dr. Ayaj, are you there?
Hello, sir. Good
Hi,
afternoon,
Dr.
good
Ayaj.
evening.
Good evening, good evening. Dr. Ayaj is again like very fond of Dr. Ayaj because he is one of the most active, I would say,
I am
candidate or
thankful to you,
trainee.
sir. Salute. I salute you.
So he always like, if like why I am saying him specifically, like he has contacted me personally for his like the troubleshootings also that we tried to do during his preparation for the EDIC 2 despite his busy schedule in Saudi Arabia. So he's from Saudi Arabia, and he also cleared successfully in this last few days back the results came and he cleared. So we are very sure that with his passion for doing something in critical care and also his dedication towards critical care, he cleared it successfully. So these are our the what we can say the achievements that we uh, achieved in our last preparatory course and current preparatory course, and they are the faculties those who would be mentoring the new trainees and candidates for our upcoming exam preparatory course. So we have also Dr. Ashish who could not join. So Dr. Ashish, are you there? Okay. So with this, I would not be taking much of your time. So the purpose of this webinar is to analyze the question pattern. Those questions, those were asked in the last exam, which was conducted in the last month, and the results were announced 5 days back. And many of the candidates from our preparatory course, they were successful, and we are happy to inform you that the success rate is 89%, which is almost like at par with any of the I would say the best institute or the preparatory course at the international level. So welcome friends, and I would be starting the webinar with 2 or 3 quotes that I want to share with you, and then I will be handing over to Dr. Diksha, Dr. Nasrina, and Dr. Ayaz for the next part of our webinar. When the going gets tough, only the tough get going. Why I am saying it? Because we are not like right now doing EDIC2 as part of our primary specialty. We have already done it many years back. Many of us are right now consultants, but despite that, we want to get some a more certification, more the I would say affiliation, and also some of the this EDIC Part 2 is one of the most prestigious exam, and you have all cleared Part 1, and now you are aiming for the Part 2. So that's why you have taken a very hard decision, despite your all the usual problems that we normally face in our day-to-day life, in our clinical life. So that's why we thought about that we should be having a preparatory course that would be definitely helping you, guiding you, and not to just let you work harder but work smarter. And we all know right now in nowadays time, it's not only the hard work that counts, rather smart work that counts. So with this is the concept that we had last year also, last the exam also, and that was also very well appreciated. And this time also we thought about a webinar which has never been tried before for this type of competitive exam. So that is recall question analysis of recently completed EDIC Part 2 exam. And the highlights of our the webinar we would be discussing now in next 1 hour or so. Dr. Diksha, Dr. Nasrina, and Dr. Ayaz would be putting some of the their thought process to clear the high yield focus questions, domains, those you are asked in the exam. And if you have any doubts related to that, you can post in the chat box. You are very much welcome to post in the WhatsApp group that we have created, and that would be active not only for this webinar, but after that also we'll try to help you out with your doubts. And I am missing Dr. Jitendra. Are you there? Dr. Jitendra is also our faculty for this course. Dr. Jitendra from Bangalore. So actually today is his birthday. So he apologized that he would be busy in his some family occasion. So nevertheless, we wish him a happy birthday, and we will be proceeding with the today's agenda. So today's agenda, we have to discuss about the EDIC Part 2 exam, the real questions, the pattern, the uniqueness about the exam, and then the candidates, our successful candidates will be discussing. And then at the end, Dr. Sanant and myself would be discussing the high yield domains, the current trends, and the final takeaways. So I'm not going to into detail of the how the exam would be the CCS CBS would be asked, because we have another webinar which is coming up after 7 days, and we are trying to rope in the real examiners from EDIC Part 2, the ESICM. So we will be updating you with all the information in next 2 days from now. So Dr. Sanant, do you want to share anything before we hand over to the faculties?
Yes, Dr. Tapas, as you said, this is the starting of the journey, and it will be an interesting pathway to appear the EDIC exam. And each year we have added few things onto our domain. Every time it is renewed, and this time we have some new faces. They will bring some new experience that will help you to stay on top of the game. As I always say, the exams are getting more tougher nowadays, and we try to keep pace with it. But the preparation, that is the most important thing to crack the exam. If we are in the right track, whatever comes in the exam, we should be able to answer and pass the exam. Now, best of luck for your exam, whether you join the course or not. And this is our effort to make you understand what it takes to get this exam done, and what commitment you need. So the time is short. We have only 3.5 to 4 months, but the course is very consolidated. And if you plan to join the course, then you need to be focused to get the best out of it. All right, and we are always at a
Sanant, your voice is not audible. Yeah.
Can you
Okay.
hear me now?
Yeah. Now it is audible.
Yeah, I have some connections issue. The power
Okay.
is
Okay.
going in and out.
Okay.
So,
Okay.
but
Okay.
anyways, I will wish best of luck to the candidates and whoever is aspirant for the exam. And we will be prepared to help you out, whatever it takes for it. Thank you.
Yeah. Thank you. Thank you, Sanant. Now I request Dr. Nasrina to just share his experience as well as his tips and tricks to the upcoming examination. Dr. Nasrina, are you there?
Hello, am I audible?
Hi. Yes,
Yeah,
yes, you are audible. Yeah.
yeah. So what I wanted to say from my side is, for me, to crack this exam, EDIC exam is not just based on our knowledge. Having the knowledge is not enough, because to answer this, we have to answer in a pattern or a structured way. For that purpose, we need to enroll ourselves into a course like tricks, because this tricks is like over a period of 6 months. It covers all the systems, and we need to prepare over these months. And in tricks, each system, there are for each system there is a 1 week time, and in that 1 week time we need to prepare. And before attending the session, it's always good to prepare and attend the session, because we gain a lot of knowledge, and after attending the sessions. So this course helps us in answering a structured way, because during exam, because of time constraint, our answers should be on fingertips. They just want to hear the point by point the answers. So to answer in such a way, we need to train ourselves over the 6 months. 6 months is required. So that is one of the tips I have learned from this course. This course really helped me a lot, and all the faculties behind this course has put so much effort in preparing the material, the questions. So this is going to benefit us in a huge way. Then, like Dr. Sananta said, now the questions are each year, they keep changing the questions. And when I attended my exam, it was based on CRRT troubleshooting, ECMO console questions, then, as usual, the ventilator graphs, all those. So we have to be very while answering it, we need to be so prepared to answer those questions. And we have to be fast, because each question is less than a minute. So enrolling into such a course is very useful. This is what I want to share from my side. Yeah. And like in the UK, here most of the patients who needs any intervention, like for example renal replacement therapy, everyone, like, they will be put on CRRT. So we have to know about CRRTs, and any patient requiring ECMO. So a lot of ECMOs, CRRTs are being done here. So we have to know right and left of these topics. Yeah.
Thank you, Dr. Nasrin. As you rightly told, as it is an European exam, so definitely the examination would be revolving around the cases that are very common in the European ICUs. And
Yes.
believe me, Dr. Nasrina, Dr. Ayaz, and also Diksha would be agreeing with me, also Sanant, that the real questions that those were asked in the EDIC part 2, so those are actually not taken from or created by the examiners. So they are
Yeah.
actually the real cases from the real ICUs. So you
Yeah.
will not get it that framed and they are creating a imaginary situation. No. So
No.
that's why you have to be taking such type of practice beforehand, so that you will not be fumbling in the exam and you will be telling something the examiner would be at least interested. So that's why, as Dr. Nasrina also pointed out, so now the examination pattern is completely changing from north to south, or I would say completely changing the direction. Okay. So
Suppose
thank
Dr.
you.
Jitendra is also online
Hi, Dr.
now.
Jitendra. Happy birthday wishes to you, first of all.
Hi, sir. Thank you, sir.
I know it's not the right time to engage in one webinar, but yes, we wish you happy birthday. And
Thank
if
you, sir.
you can share some of the tips and tricks to the candidates, I know you are busy.
Happy birthday,
Anyways,
sir.
first of all, congrats everyone. You already cleared your part one. So this is your next step in getting your degree. So and as always we say, so it is nothing. You sit in catch hold of a book, sit in front of a book and read. No, it is not like that. So this is what you're expected to do when you see a case bedside. So whatever you are doing bedside, that is what is expected in your EDIC 2 exams. So don't think you'll sit last 10 days, 15 days, do a crash course and you'll crack your EDIC 2 exam. That will not be possible. So whatever you do, practice it bedside. So same things will be asked in your exam also. So imagine that you are having a real case scenario in your patient and you're doing whatever you're doing for your case at bedside. That is what will be asked in the exam. And sir, as you rightly said, those are not cooked up cases or something they prepared by discussing with people. Those are all real time cases because all our exam cases were all real time cases. So whatever has happened in their ICU is what they are discussing with you. And however they have managed, they are expecting you to manage in the same way for better results. So practice at bedside. So read images, whatever is there. So images, graphs, ECGs, biochemical scenarios, case discussions, echo findings. So everything is what you are doing at bedside. So that is what we'll also be giving you hints, and we are not here to teach you anything. So we are just making you oriented to the exam. So whatever you know, we are just fine tuning you. So and you'll learn things as we go around for the next 3 months from the day we start our modules. So we'll get to exchange a lot of things. Okay.
Thank you. Thank you, Dr. Jitendra, for
Thank you,
those
sir.
wise points, and we will be definitely helping the candidates. Now, Dr. Ayaj, are you there?
Yes, sir.
Hi. So, Dr. Ayaj, could you please share your experience because you just cleared your EDIC Part 2 exam. You are in Cloud 9 now. Yeah.
Good afternoon and good evening. I'm really happy to share that I have recently passed my EDIC Pass 2 exam that was conducted on May 21st. I passed all the 3 clinical case scenarios and all the 3 computer-based exams. I contribute all my success to this 360 critical care course that I attended. It was really great help to me. It was a great experience. Actually, this course included modules on all the topics that are being asked. They give us the material regarding any topic, and we have to prepare that for 1 week. At the end of the week, we have to appear in the exam. The best thing is that after 2 or 3 days after the exam, they conduct the debrief of that topic. That was the most helpful, I think, for me. What I did in the last 2 weeks while I was preparing for this exam, I just watched those debrief videos. And those debrief videos were they were extremely helpful to me. In addition to that, the second thing that gave me confidence to appear in the exam and to answer the questions during my exam was the mock tests. At the end of the course, they conducted the mock tests, and those mock tests were extremely useful for me to clear the exam. I highly recommend this course as a preparatory course to clear the EDIC exams. And I'm really thankful to Dr. Tapas sir and his team for this wonderful mentors, wonderful faculty he has arranged in this course, preparatory course for the EDIC exams.
Thank you. Thank you, Dr. Ayaj. And we are really, really motivated by your all these positive points. And definitely, we would be continuing to help the upcoming trainees also who will be enrolling in our course. Thank you very much. Much
And
appreciated.
in addition to that, I will like to add one more point. that in addition to these debrief videos, which are very interactive, we were having a WhatsApp group, and that also helped a lot because the co-exam goers and the faculty, any doubts, anything, they were posting in the group, and we were getting very fast response in that group. It was really very helpful. I once again thank Dr. Tapas sir and his team for helping me to clear the exam.
Thank you, Dr. Ayaj. And we will be definitely seeking your guidance as well as help for our upcoming courses. Okay. So
Thanks.
now without any much like I would say discussion further, the main agenda for this course or this webinar for today is the recall test, the questions and also their analysis. So before that, there were some questions in the chat box. So we would be announcing our upcoming exam. It would be started by this month end only. Only I would say maybe 7 to 10 days after we are starting our course. So the registration would be happening tomorrow. So we are waiting for the registration to happen so that people would be very sure about their the confirmation of getting the seats for the exam. And also there would be many candidates who have also said with us before that they want to get the first hand experience. They are not appearing the November session, but they want to get the idea how the examination normally should be prepared. So for them also, you should join this course so that when you will be surely getting the test or the examination, so you would be at the top level in the list. So we would be informing you everything in the group, WhatsApp group. Don't worry about that. So now I would request Dr. Diksha to discuss about the CCS and CBS. Before that, one disclaimer from my side or from the 360 critical care side that these are the questions which are taken from the candidates who have appeared the exam, real EDIC 2 exam. So we at no point of time guarantee that the same questions or the exact questions were asked in the real EDIC part 2. This is one attempt to help you all, because this is something which we want to keep as a disclaimer that we are here to help you out. So this has never been tried before for any of the similar type of exams in the critical care. So this is a novel attempt, and for that we are really thankful to all the candidates for our like from our course, those people who have actually collected and shared the questions with us and also shared their opinion. We have tried to frame the answers, the real like the exact answers, but yes, that would not be like I cannot give guarantee, or the speaker who will be now narrating the answers, they are also not very sure that this would be the same answers picked up by the EDIC examination committee. So don't go with the answers, but yes, try to know, yes, these are the high yield domains, those who were asked in the last exam. So this is something which we want to highlight. Thank you very much, and please go through these questions. This is a very vast presentation, so I would request Dr. Diksha to just go through the questions and the suggested answers so that we can finish it in time also. Thank you.
Thank you so much, sir, for giving me this opportunity. And thank you to the whole tricks team for guiding us. That's why we could do it. And I'm really grateful to help others in their EDIC2 journey. So let's start with the recall. I hope you all can see my screen and can hear me.
Yes, it is visible. Yeah.
Okay. So first we will discuss the CBS questions. So the day one would be CBS and day two would be CCS. CBS is computer-based screen questions. So there will be a vignette and you have to read all the question, all the parameters given, labs, including the imaging, and answer the question specific to the point. That is the CBS. So first we are starting with the first question of CBS. So I'll just read the question for you and you can answer in the chat box about your answers and so that it would be an interactive session. So question one, 28-year-old female, previously healthy, presenting with fever, increasing fatigue for 10 days. On examination, there was hepatosplenomegaly, temperature of 39.2 degrees Celsius, heart rate of 112, respiratory rate of 26, BP of 90/50. She had no significant history of recent travel, animal exposure, or sick contacts, and her biochemical parameters were just arrived for you. So HB of 8.2, TLC of 2.1, platelet of 60,000, AST, ALT of 120 and 180 respectively, bilirubin of 2.8, ferritin of 15,000, triglycerides of 350, fibrinogen 1 gram per liter, urea 8.5, creatinine 100 micromoles per liter, and IgM HAV reactive. So the first question for you is, what are the abnormalities you can see in the case? So you have to jot down, the time is very limited. There is just time of 1 minute for each question approx. So you have to be very quick in analyzing your question. You have to see all the positive points and pick them up quickly. First of all, the initial questions are regarding the first positive findings in the question. So what are the abnormalities here which you can see? So here you can see the fever is there, tachycardia, tachypnea, hepatosplenomegaly, anemia, lymphopenia with thrombocytopenia. And there's deranged LFT with raised ferritin and triglyceride levels and IgM HAV reactive. So what is the likely diagnosis here? Can anyone put it in the chat box? Let me see the chat box. Yes. So yes, a lot of you have started answering. So yes, it indicates HLH. So HLH is your likely diagnosis here. How you will diagnose this HLH? Okay, so you have to do the HLH criteria. Soluble IL-2 receptors, CD25 markers. You have to do the bone marrow biopsy if possible for the definitive diagnosis. And what are your treatment options? So immunosuppressants like corticosteroids, chemotherapy, etoposide, plasmapheresis for refractory cases, and obviously supportive care. So you have to answer everything within the time frame of 1 minute. That is challenging. So you have to learn to pick up the clue points from your question vignette. So that you can be very quick in answering and you can give the to the point answer. So each point carries 1 mark or marks according to the weightage. So you have to be very quick and you have to learn to correlate all the dots and come out to the final decision of what is your diagnosis, how you will diagnose it, all the treatment modalities. Coming to the second question, 61-year-old alcoholic male presented with fever, neck stiffness, and altered sensorium. And the CSF study has been done, which showed a white cell count of 800 per millimeter cube with lymphocytic predominance, protein of 120 milligrams per dl, glucose of 30 milligrams per dl, RBS of 140 milligrams at the time of NP study. So the first question here is, what is the likely diagnosis? It is quite clear cut. Meningitis, likely bacterial as per the CSF study. And so here the likely pathogens they will ask. So you have to, very good. You have already answered in the chat box. So Listeria is the quite common organism here because provided the immunocompromised kind of background, extreme age with alcoholic background. So Listeria you will answer here as the pathogen involved. Then what will be your treatment option? So ampicillin and supportive care, plus they can go on to if he's allergic to penicillin, what would be your treatment modality? Yes, rightly said, cotrimoxazole. So moving on to the next question. A TBI patient is throwing recurrent seizures and he's achieving burst suppression with thiopentone infusion only. His sodium levels are 155 and potassium is 2.7. What are the feared complications of potassium correction in this patient? So can you think of feared complications of if you correct the potassium here? Yeah, so in the previous question, there was an error of that was neutrophilic predominance, not the lymphocytic predominance. So apologies for that. So yeah, in this question, the patient has received thiopentone infusion and we are able to achieve burst suppression. But now what patient's potassium level is 2.7. So you would like to correct it by giving potassium correction replacement. So what are the feared complications here of potassium correction in this patient specifically? Can you think of something? Okay, somebody is answering arrhythmias. Fine. Arrhythmias can be because of potassium, low potassium itself. But specifically, if you give potassium correction, what are the fearful complications here? Anybody? So this was relatively tougher one. So you have to relate it with the drugs ongoing to the patient. Yes, somebody answered further rise in basically there would be rebound hyperkalemia with the use of so thiopentone causes intracellular shift of the potassium. So there would be raised intracellular potassium levels. And if you stop thiopentone once you have achieved burst suppression, so there would be rebound hyperkalemia. So you have to be very careful with your potassium replacement which you are giving. So you have to keep an eye on the serial potassium levels and prevent this rebound hyperkalemia.
One thing, Dr. Diksha, just like no sharing with everyone. So this is question related to the intracellular potassium shift, and thiopentone is notorious to do that. So that's why they have categorically asked about thiopentone and potassium relationship. So if you know it, then you can immediately answer that this is due to the intracellular potassium shift. So once you stop thiopentone, definitely now the potassium from intracellular now will go to extracellular and the potassium would raise. So that's the reason why you have to be very cautious while you are stopping the thiopentone and changing the potassium. Yeah, continue.
Okay, so next question. 54-year-old patient with multiple myeloma was shifted to your ICU after receiving a CAR T-cell therapy. He's febrile with respiratory rate of 35, heart rate of 105, BP of 110/76, and CBC of HB of 9.4, TSG of 20,000, platelets of 1.3, sodium 132, potassium of 3.5, phosphorus 0.5, magnesium 0.75, and calcium of 2.1. So what are your differentials here? So very be careful about these questions regarding the newer therapies which are coming up, like CAR T-cell therapy. So highly they might ask CAR T-cell therapy in your CBS or in your clinical case scenario also. Okay, so yes, CRS, somebody rightly said. So there is CAR T-cell therapy related adverse effects, cytokine release syndrome. It could be sepsis, new onset sepsis, your TLCs are rising, HLH, or allergic or anaphylactic reaction. So then next question, what will be your next steps in managing this patient? So the question can be straightforward, very short, or it could be a broad question answer. So you have to answer to the point for the broad question in a systematic manner within that time frame. So you have to send the sepsis workup, ferritin levels, triglyceride levels. So you have to direct your answer as per your differentials. The sepsis workup, because sepsis is one of your differentials. Then ferritin and triglyceride levels for your HLH workup, and also you have to divide your management in terms of workup plus the therapeutic treatment. So you will do the treatment with steroids, IL blockers, prophylactic antibiotics, your sepsis bundle. You will follow electrolyte replacement, transfusions if required, and supportive care. Okay, so next question. An asthmatic intubated patient is being shifted from ICU to CT scan, and his ventilator is giving continuous alarms. This patient is having bronchospasm on auscultation. An accompanying doctor does something on the ventilator, and this is the ventilator screen of the patient. So there will be 2 to 3 questions regarding the ventilator screen. So you have to know the patient ventilator asynchronies. You should be able to pick them up quickly, and what are the fixing troubleshootings for them. So here what you are able to see, what is the maneuver which the doctor has done. Any one of you? This is quite commonly we do. Yes. So why we are doing it? To look for what in this patient specifically right now? So that would be the next question. Yes, right. So here the doctor is performing the expiratory hold maneuver and to find out the intrinsic peak value. Right, very correctly said. This is quite common, but you have to be quick in terms of picking it up and answering to the point. That is a thing you have to learn. Okay, next question.
Just interrupting Dr. Ayaz and Dr. Nasrina, please share your thought process also for any question which you also wish to share with the candidates. Please feel free. Okay.
Yeah, in the ventilator graphs, like what I remember from my exam is they can ask both on the mechanical ventilator as well as the BiPAP, CPAP graphs also. So we have to keep in our mind to learn those graphs also. So the one which was asked for my exam is those typical ones like missed efforts, ineffective, triggering. So the next question will be, how do you correct it? So you have to list those answers. Then the other one was the ventilator graph on when the patient was put on nebulizer, the volume, expired tidal volume was not delivered. Uh, it was low on the lower side. So these questions you can expect. So they asked the question, what's the problem here? Why the delivered tidal volume is low? So these are the two questions from ventilator graphs. Definitely there will be question from ventilator curves. But we have to be thorough with those.
Thank you.
Mm.
Yeah.
So moving on to the next question. So here is the image you are able to see. So you are supposed to answer what is this image shown? What is this modality of imaging? Can anyone tell? Okay, somebody is writing any reason. Okay, what is this modality? Okay, yes. So it is brain angio, four vessel angio of the brain. Yes. You see the brain angio. And what does it signify here? What is the abnormality? So basically it is indicating absence of the intracranial blood flow. There is, you can see the IC intracerebral artery, if further blood flow is occluded, there is no flow and it is indicating brain death. So it is one of the ancillary modalities of the checking for the brain death. So you have to know all these different, I mean, all those questions which you are not commonly doing. So brain death and end of life care is something which you have to know about brain death. Yes, yes, Dr. Ayas, you are commenting something for this question.
No, it's okay. Please continue.
Okay. So you have to know about all the ancillary testing for brain death and also the end of life care. All the questions would be there in CBS and CCS both. Okay, so moving on to the next question. So yes, you will be given many monitor screen of the patients with the ECG, with the arterial wave, invasive arterial waveforms and the CVP waveforms. You have to learn them in and out every question regarding them. So here, what is the abnormality in this monitor screen? You are able to see. Okay, so there is an ECG. Is there any abnormality in the ECG? And correlate it with the invasive arterial waveform and the CVP waveform. If you are not able to pick up, try to find the correlation between all the waveforms so that it can make sense to you. Okay, no, it is not octanence. Anything else? So are you able to see something very abnormal in your CVP waveform? The huge A waves, Canon A waves you're able to see here. And you have to correlate it with your ECG.
This is an excellent question. I also initially found it very difficult to just appreciate. But when I analyzed it further, it is an excellent question.
So when they give you the ventilator screen, they want you to analyze it, hold together all the parameters so you can understand what is happening wrong with the patient right now. So here, the initial part of the ECG you can see is showing junctional rhythm with a large A wave, Canon A wave in the CVP trace. And the later part of the ECG is showing normal sinus rhythm with normalization of the CVP trace also. So here you can correlate. Then you know that Canon A waves in CVP trace are a hallmark of the AV dissociation, especially in junctional rhythms or complete heart blocks. And restoration of sinus rhythm leads to normalization of your CVP waveforms. And recognizing this pattern can help in diagnosing rhythm disturbances and assess the hemodynamic consequences at the bedside. So it is kind of correlating your hemodynamics, connecting the dots and helping your patient overall out. So going on to the next question. So let's see you are able to answer this one or not. This is relatively common and easy. 40-year-old alcoholic male is admitted with fever and a history of on and off abdominal pain in the past 3 months. And he was hospitalized previously for 2 weeks and discharged in a stable condition. And now his current CT is this. So can you tell me what are the abnormalities you are able to see in the CT imaging here? So they are very fond of CT abdomen images, and we are also having patients at our bedside. So have the pain in picking out their CT films and seeing them on your rounds regularly, because usually we see in the definitive written report from the radiologist, and then we'll try to correlate. But you are supposed to know the CT imaging finding by yourself without the help of radiologist, because it is something sometimes emergency definitive treatment decisions you have to take, and you cannot wait for the report from the radiologist. So you should know your imaging. Okay, so somebody is pointing out, yes. So this is a pseudocyst. So there are multiple well-defined organized cysts you can see in the pancreas. So what does the CT picture shows? So multiple peripancreatic pseudocyst collections. And what will you do for the source control in this patient? So you have to tell all the modalities of treatment here: endoscopic guided drainage or percutaneous drainage, or surgical open or laparoscopic cystogastrostomy can be done. So everything is having 1 or 2 marks according to the weightage. So every point carries some marks. So you have to be, we have to practice to answer them within the time frame. Okay, so ECG. So there would be 2-3 ECGs in the CBS section, and there would be involvement of ECG in your clinical case scenarios also. So ECG is that part where you have to practice and you have to improve your ECG skills. Time is limited again, 60 seconds. You have to answer all the questions, and they can give you tough ECGs also. So let's see in this ECG if you are able to find out. So it is a 65-year-old man with breathlessness with which is increasing since last few weeks, and the ECG has been done. So what are the abnormalities seen in the ECG? What does the ECG show? So you are able to see the answer. Okay, so there is irregular rhythm. So atrial fibrillation with a ventricular rate of about 40 per minute, and there is left axis deviation. You can see in 1 AVL, 1 and 3. Then there is a left bundle branch block also. You can see W in B1 and M in B5, B6. Then how you'll manage your patient. So whenever they ask you management, they want you to tell both the workup. So you will do 2D echo, cardiac biomarkers, and the treatment. So you will use diuretics, NIV, ACE inhibitor, that definitely might be pacemaker also.
And
Then
just wanted to say, for my exam, they had asked Brugada. So syndrome ECGs can also be asked. Brugada, long QT, all those ECGs and the treatment for that. So I think when they give the question, our half of the our diagnosis should be there in the after reading the question, we should have a diagnosis in our mind, and then we confirm it by looking at the ECG. I think that's how it works sometimes.
yes, rightly, as pointed out by Dr. Nesina. So you have to correlate the question statement with your imaging provided. So don't answer them individually. Use, combine both the things. Whatever they have given in the question stem, correlate it with the imaging or the graph or the ECG provided. So that is really helpful for you to pick out the abnormality quickly. So it is about pattern recognition. Okay, so let's do this ECG question. So what does the ECG shows here? Can anyone tell? Try to read this ECG. Okay. Yes, there is a block. 2:1 ratio fixed block. Anything else? Try to find out all the abnormalities. So each abnormality in this carries some marks. You have to read it holistically. Don't miss out on points. No U wave. That is the P, which is because of the fixed 2:1 block. Oh, yes. So somebody has rightly pointed out RBBB is there. And can you see these large S waves in 2, 3, RS pattern? No, S1, Q3, T3, that is left anterior fascicle block. So it is 2:1 second degree AV block with bifascicular block RVBB. You can see here M pattern in V1 and W in V5, V6, and your LAF left anterior fascicular block. So your big S in 2, 3 AVF. Then how you will manage this patient. So you have to always use this to give the right consultation at the right time. So cardiology consultation has to be given here, and patient might need permanent pacemaker. So we'll
Can
do
I comment on this ECG, please?
yes.
Yeah, yes,
Yes.
please.
Sometimes once they go for the pacemaker, whether we find pacing spikes in the ECG or the patient is indicated for the pacemaker, they ask for how do we set the voltage and how do we set stimulation threshold and how do we set the sensitivity of the pacemaker. So we may have to read about those things regarding the setting of the pacemaker, voltage, stimulation output, and the sensing threshold.
You have rightly told, Dr. Ayaz, pacemaker is a high yield domain for EDIC Part 2. Everything you need to know about pacemaker.
And our mock test,
Yes.
last mock test had we had covered this topic also, sir.
Yes,
I
yes,
think it would have
Yeah.
benefited all the students, I think.
yes,
Yeah,
yes.
exactly.
Yeah. Okay. So,
Okay.
Dr. Diksha, I
Yes,
know
sir.
there are a lot of questions. So, if you can just start the CCS questions, because CCS also it would be 2 CCS we will be trying to finish, and remaining questions we will try to give or maybe post in our WhatsApp group in between, because it will not be possible to cover so many things and it would be just rushing. We don't want to do that. Okay. So, if you can just share the CCS questions.
Yes, sir.
Yeah.
So is everyone able to see my screen?
No, your screen is not visible.
Sure.
At the end, I would be sharing with you 4 slides about the recently completed EDIC Part 2, which were the high yield domain questions. 4 slides only. So don't worry. Okay.
Is my screen visible now?
Yes, yes, it is visible.
Okay. So let's do the clinical case scenarios. So each scenario would be of around 18 to 22 minutes, and the case would be evolving just like your patients do in your clinical rounds. So every day or progress of the patient, involvement of the case, that is the clinical case scenario. So let's start with the first clinical case scenario. So you will receive the first vignette and you will be having, this will be the busiest slide you will have in your clinical case scenario. There would be lots of information and you will be given 10 minutes or so to read all this information, to make your provisionals, to summarize the case in your head, and you can jot down the points from the screen. So this is, let's begin with it. You received a 48-year-old man in your ICU post-operatively, and 3-segment hepatectomy for localized hepatocellular carcinoma was done. He is on a ventilator support with pressure controlled mode, respiratory rate of 15, pressure support of 12, and PEEP of 6, with FiO2 of 0.5, along with 6 abdominal drains in C2. And he had a blood loss of around 1.5 liters intraoperatively and has received 4 FFPs, 2 PRBCs, and almost 6 liters of Bristolites. His vitals are heart rate of 120 beats per minute, BP of 80/60, on NORAD of 0.04 mics per kg, and he's on propofol and remifentanil infusion. Then you would also be having some of the investigations along with this clinical case vignette in the first slide itself, some ABG. So the labs of this patient, the HB of 8, TLC of 8500, platelets of 80,000, INR of 1.8, APTT of 55, and creatinine of 1.1, lactates of 10, troponin I of 1000, ammonia of 155, pH of 7.25, PCO2 45, PO2 of 131, bicarb of 19.6, sodium 139, potassium of 3.9, and chloride of 102. And then there would be some imaging along with it, some point of care investigation, like here they have given the rotem, the XTEM, NTEM, and the FIBTEM graphs. So whenever you get this initial vignette, you have to jot down all the points, make your provisional diagnosis. Yes. So initial question would be regarding the summarize the case or tell the positive findings of the case. What is your provisional diagnosis or differentials? So, yes, people have started answering. That is good. So, yes, all your positive findings. And so, what your question is, what is your assessment of this case, or summarize the case? Yes, the patient is in shock. Hypovolemia or septic. Yes, somebody is answering resuscitation and transfusion. Okay. So you have to pick up all the important positive points and clues from the vignette. So this is a post-operative hepatic resection case of a hepatocellular carcinoma. So underlying pathology, keep in mind, because that is related, that you would be able to relate it with another thing coming up. So hepatocellular carcinoma, coagulopathy, you can relate to. Then significant intra blood loss was there. Shock on vasopressors and deranged coagulation profile and rotor, deranged rotor graphs, hyperammonemia, hyperlipidemia, and raised troponin. Then you have to describe the ABG. So always, while you're analyzing your initial vignette screen, if the ABG is provided, try to analyze the ABG in that 10 minutes itself. ABG interpretation, including the primary pathology of the ABG, the compensation, and the oxygenation level, hypoxia, if there is, don't miss it. Then lactate levels. So here, what is the ABG showing? Can you read the ABG for me? And can anyone tell the ABG findings? So pH is 7.25. There is acidosis. Okay. So nobody wants to practice it. Okay, somebody saying primary metabolic acidosis. Okay, yes, metabolic acidosis. Okay. Compensation. Yes, with additional respiratory acidosis also, rightly said. What about other things as I told, lactates? So very high lactate levels, hyperlactatemia, very good. Okay. So your ABG is mixed metabolic and respiratory acidosis. Always, I also miswrite. So you have to calculate anion gap whenever there is metabolic acidosis and they have provided you with sodium, chloride, bicarb levels. So you have to calculate your anion gap. Don't miss it because it carries marks. So you have to calculate anion gaps. There is high anion gap metabolic acidosis with hyperlactatemia. Then the ROTEM which was provided to you. So how do you assess ROTEM findings here? So you have to learn ROTEM because they can give you ROTEM in your CBS also, and it would be part of your clinical case scenario as well. So learn ROTEM in and out. It is not very difficult. You have to just practice it. So the clotting time was prolonged on both extem and intem, indicating deficiency of clotting factors. Then low maximum clotting firmness on the extem, intem, and fiftem, indicating your platelets are low, and on fiftem, 8 and levels are low. So fibrinogen level is also low. So there is hypofibrinogenemia with deficiency of platelet, and your clotting factors are also deficient, right? So somebody has rightly said you will transfuse FFPs and cryo and platelets. So you have to do your point of care rotor transfusion, guided transfusion of the blood and blood products. Okay. So the patient requires blood and blood products administration with the use with FFP, cryo, and platelets. I'm trying to minimize this chat box. Give me a second. Okay. So the case will evolve further, and then they will ask you another questions related to the case. What can be the causes of shock in this patient? So in the beginning, you summarize the case as having shock. So what are the causes of shock here? So whenever you will get this kind of question, you have to say all kind of shocks which are involved in this case. Hypovolemia, yes. Somebody said vasoplegia, so septic shock, right? So hypovolemic or hemorrhagic. So there was massive blood loss, so hemorrhagic shock, hypovolemic shock, and the troponin I level was also raised. So cardiogenic shock would also be there. So how you'll approach to the shock of the patient here? What would be your approach to the shock? So as you said, somebody said vasoplegia, sepsis, hypovolemic. So how you will approach this shock? Again, this question is broad, but you have to be very organized in your answering here. Okay. So we are answering everything in bits and pieces, but we have to answer here in a organized manner. So patient requires simultaneous management of bleeding and compromised cardiac output. So we have to take care of hypovolemic and cardiogenic shock together. Invasive hemodynamic monitoring has to be done. Bedside focus you have to utilize, and assessment of fluid responsiveness you have to see. Then you have to minimize crystalloid use and judicious use of fluids and early blood products has to be done. And dotum guided transfusion of blood and blood products has to be done. You have to titrate your inotropes and vasopressors according to your MAP targets. You have to monitor perfusion with respect to capillary refill time, serial lactate levels, and urine output. Patient might require mechanical circulatory support or urgent PCI also, as there was cardiogenic shock. So you have to answer in a holistic manner. You have to cover all the points, and that is something you will learn with practice. So the case will evolve just like your patients perform in your daily clinical round. Every next duty, you have to see how the patient is behaving. So the vignette 2, this patient is transfused with FFP, cryoprecipitate, and his BP is still 90/50 on norepinephrine of 1 mics per kg. His urine output is 40 ml in the last 6 hours, and lactates is 17 now in the EBG. So what will be your further approach to this patient now? The lactates are rising. Still patient is in shock. And the urine output is dropping. So somebody is rightly coming on to RRT. And which modality? CRRT you are saying, okay. So which modality of CRRT? Your next question. Yes. Yes, rightly said. So you'll consider initiating CRRT here, and your modality would be CVV HDF, right? And why you are using this modality? Why you are not using other modalities? Why you are using CVV hemodiafiltration? Yes, rightly said. So hemodynamic instability is there, rising vasopressors, and hyperammonemia is also there. You have to remove all the larger molecules also. It will also help in removing the larger inflammatory cytokines also. So what will be your prescription? So they will not just stay till your CRRT and CVV-HDF. They want you to know the complete prescription of CVV-HDF modality. So what would be your prescription here? So what all points you take care of while putting the prescription of CRRT, CVP, HDF? Okay, dose, fine. What other things? So every point in the prescription carries the marks. So you have to be complete in your answer. Dose, right? Then next, blood flow requirement, yes. Dialysate replacement, yes. You are coming on to it. So first of all, to begin with, you have to say the access. So hemodialysis catheter in right internal jugular vein or femoral as per the access available. Then blood flow 120 to 200 ml per minute. Then dose of 30 ml per kg per hour. Then dialysate of 1000 ml per hour. Replacement fluid of 1000 ml per hour. You have to divide it 2/3 pre-filter, 1/3 post-filter. And ultrafiltrate rate of 20 ml per hour with, don't forget to mention the anticoagulation. So here you can use regional citrate anticoagulation. So this is your complete prescription. You have to start from the axis, blood flow, dose, dialysate, replacement. Ultrafiltrate, you can target, you can say I will target as per the hemodynamics of my patient. And regional, the anticoagulation part you have to mention, whichever anticoagulation you would like to. So here we can use regional citrate anticoagulation. So the patient is having high risk of bleeding also. There is liver involvement, so we have to be careful when we are using RC, but if we use heparin, then also there is risk of bleeding. So here you have to decide accordingly, whichever you will use, you have to justify it. So let's see, here we are using regional citrate anticoagulation. There is no absolute contraindication, you can use it. Yes, you have to be, you are coming rightly there. Somebody mentioned in the chat box, you will be careful about calcium. So let's see what is the next question. Can you tell me why the lactates are rising in this case? Yes. So here, the liver involvement is there, so clearance. So first of all, we'll start with the shock. So there is shock, hemorrhagic shock. So lactates are rising because of the anaerobic metabolism. So cardiogenic, inadequate oxygen delivery, and hepatic pathology and surgery. So impaired clearance of the lactate. So all these are the reasons of rising lactate levels in our patient. So the case is evolving. You have started CVVHDF with RC. The next day, his calcium requirements are rising. Total calcium of 3.9 and ionized of 1.1. So what is the problem here? Why is this happening? Okay. So yes, you are using regional citrate anticoagulation. Very correctly mentioned. Right. And what changes you will do in the CRRT? If you are able to pick up that there is some problem with the citrate toxicity. Okay. So there is increase. So you have to answer it this way. There is increased calcium gap. Total calcium to ionized calcium ratio is more than 2.5. And along with increasing calcium requirements, and therefore you suspect citrate toxicity here, decreased metabolic conversion and accumulation of citrate calcium complexes in the blood. And how you will, what changes you will do in the CRRT prescription to overcome this? You can increase the blood flow, increase the dialysate, and discontinue your citrate for some time and analyze your calcium level serially. So your case is evolving, and post-operative day 7, patient is off sedation, coughing on tracheostomy with secretions. His TLCs rose to 20,000. His BP again dropped and required norepinephrine support now. So what are the reasons you can think of this picture coming up? Yes, this is a common scenario we face in our daily rounds. Yes, so new onset sepsis with shock. So you are thinking of various sources of foci of infection. Then what can be the source of infection in this patient? So your next question, you have to, the way that in which direction the case is evolving, you have to predict your next questions accordingly. So you can be better prepared. What will you do to investigate this sepsis now? So you know, you have already answered VAP, everything. So let's see. So you can think of sepsis here, VAP, bloodstream infection or UTI coming up, or there is some history of coughing or tracheostomy with secretions, and patient suddenly becoming hemodynamically unstable with heavy norepinephrine support with low BP. So it could be pneumothorax. Then what can be sources? So lung, hospital-acquired pneumonias, ventilator-associated pneumonias, abdominal drains, bloodstream infections, CLABSIs, CORTIs, and some pressure sore-related infections also. Then what you will do to investigate his sepsis? You'll do BAL, you'll send gram stain in the BAL cultures, then paired blood cultures, urine cultures, and abdominal or cytic fluid cultures also. Yes, rightly answered. So you can use your focus also in between to evaluate for all these things. Okay, then the post-operative day 14, patient is conscious of sedation on pressure support of 15 and PEEP of 6 with FiO2 of 0.5. And do you think he's ready for weaning? Do you think your patient is ready for weaning here? Okay, yes. So you are correctly mentioning that the support of the ventilator is relatively, the pressure supports are high. So you would like to decrease it first of all. What are the weaning criteria you will monitor in this patient? So when they're asking you whether the patient is ready for weaning or not, they can ask you weaning criteria. So you all know this is quite commonly we do every day. So no, the patient is not ready for weaning. I would like to reduce the pressure support to 7 to 8 and FiO2 of 0.4 and monitor for another 30 minutes to 2 hours. And weaning criteria, the clinical criteria. So you have to see the resolution of the primary pathology, hemodynamic stability of the patient, absence of any ongoing vasopressor supports. And also you have to see the reduced requirement of the vasopressors. The PF ratio is more than 150 to 200 with the minimum support of PEEP of 5 to 8 and FiO2 less than equal to 0.5. And also you have to see that there is no evidence of any new infection or myocardial ischemia. And the patient is conscious, alert, able to protect the airway. So this is the end of our first case. So this is this is just like if you practice on your daily round meticulously with everything involved, like all the imaging, ABG readings, all how the case is evolving, how you have to do. So this is just like your daily rounds, but the time is the limit here. You have to do everything, all of this in 15 to 20 minutes.
Yeah. So
So
Dr. Diksha, just like now adding, you have nicely summarized the whole case. You started from like no liver resection surgery, so surgical ICU, specifically liver, and then you have traversed through like no the shock, then ABG, then CRRT, ROTEM, then again difficulty in weaning, then complications in the ICU, then again like you managed it with all the complications also, and at the end you have given like no that maybe they would be again adding something difficult winning and something happened and how you are prognosticating the family. So in one case they have like no taken your total critical care journey. So that's the beauty of EDIC part 2, and they try to do it in 3 cases. So can you imagine, it will not be like no a single thing which would be left out. So for that, you have to ask everyone in this webinar, they have opined that you have to be thorough. You have to attend to all your clinical cases in your bedside, like no examination. And also you have to create that like no how to speak in the exam and narrate it, structure it and answer it to the point. Yeah. Any point at this point, like from the faculties before we will be going with the this next one?
Regarding one of the cases,
Yeah.
excuse me,
Yes, please.
with hypovolemic hemorrhagic shock came from the OR. It was documented once we received him in the ICU. The RAS was -5. It was for me what I missed in my exam, so the other people can learn from it. I noticed this in the first vignette that this, the problems were mainly hemorrhagic shock, and he came with the heavy sedation with propofol, midazolam, and something else, fentanyl, with a RAS of -5. During the management, once the case evolved, I did everything well. And at the end of the vignette, he was asking me, what else, what else, what else? But it didn't come into my mind that RAS was -5, although I noticed it once I read the vignette for the first time. So the most likely the answer was to check the sedation level. Maybe I can decrease the propofol, I can decrease the fentanyl because the RAS was -5. That's it.
Yeah. Thank you. Thank you. Okay. Thank you. Dr. Diksha, please proceed.
So let's go on to the second case. So out of 3 cases, there would be one case which would be divided into part A and part B. So this would be the longest case. There would be 2 separate cases, 2A and 2B. So let's start with this case. So 58-year-old lady was received by EMS, Emergency Medical Services. Her husband, who is abroad, called the EMS as she was not answering the call. On examination, she was spontaneously opening her eyes, uttering words which were incomprehensible and localizing to pain with weakness observed on her right side. On examination, her heart rate was 130 per minute, irregular, and a BP of 160/90. So the lab parameters, HB of 10.6, TLC of 9800, platelets of 1.8 lakhs, creatinine of 0.98, sodium of 138, and potassium of 3.8. So they would be highlighting some abnormal lab findings for you in red so that you can easily pick them up, and they would be giving you normal values alongside of it. Then the coagulation parameters are also given along with LFT. So INR of PT of 28, INR of 2.3, APTT of 48, OTPT of 28 and 38, CRP of 23. So the first slide again, as I told you earlier, the first vignette would be the busiest slide. Even this is relatively less, which we could recall we have mentioned. There would be all the findings will be given here, and you have to pick up the positive findings out of it and plan your initial summarizing your case in your head, planning your differentials, your provisionals, and accordingly, how you have to predict how the case can progress. So, what are your differential diagnoses here? Yes, it could be stroke. Yes, AF is also there. IC bleed. Yes, you are rightly thinking in the correct direction. So differentials could be cerebrovascular accident, ischemic or hemorrhagic, subarachnoid hemorrhage, subdural hemorrhage, or mimickers. You have to see a stroke mimickers also, hypoglycemia, seizures, cerebral venous thrombosis. They are very fond of cerebral venous thrombosis. So be sure to keep it in your differentials. If you'll not keep in your differentials, then you'll not get the marks and the case might evolve in that direction. Then neoplasm, it could be neoplasm, space occupying lesion, or meningitis. Apart from hemodynamic optimization, what is the next thing you will do in this case? Yes, you would like to go for imaging. Okay, so first of all, you have to start with your mimicker. So you have to check the random blood sugar of the patient. You have to do the ECG. Patient is having irregular rhythm. You have to obtain the history, time of onset, medications which the patient is taking. Somebody pointed out anticoagulation. Yes, so you have to take the history of that. Then you have to send the complete blood counts, PT, INR, APTT, tropi, and creatinine levels. And you have to do your imaging, NCCT brain, and you have to assess your NIHSS scoring system also. Then the case will evolve. They have provided you with the X-ray of the patient. The bedside X-ray was done, and this was the X-ray. So whenever they will give you some imaging, the first question would be, what are the findings you can see in this imaging? So what are the findings you can see in this X-ray? Can you mention in the chat box, please? Okay. PPI in C2, yes. What else? Okay, pacemaker, yes. Yes, so there is valve. So when I answered like valve, they were like, which valve? So you cannot be like, it could be this, that. No, they're asking you specifically, which one is it? Okay, so we are answering. Somebody saying aortic, mitral, aortic. Okay. So I said there's a way of how to find out which valve is it. So the imaginary line from the LA appendage to the right the cardiophrenic angle, and if the valve is above it, it could be pulmonary aortic, below, so mitral or tricuspid. So that valve was lying above. So I said either it is pulmonary or aortic. So they're like, which one? So it was below the aortic knuckle, and that was an old bioprosthetic valve. So it was not very elliptical. It was relatively rectangular. Bioprosthetic valve was there, very old. So that's why it was little difficult to judge. So imaging which they will give, the quality can be poor, and it would be the real case, just like real case scenarios, it would be difficult to pick up the findings, but you have to connect the dots and accordingly decide. So yes, this is high likely an aortic valve. So after seeing this X-ray, what can you make about her past medical history? So what all you can think of her past medical history as per this X-ray? So in the X-ray, there are sternal wires also. So yes, anticoagulation history you can think of. Okay. So aortic valve replacement done in the past, double chamber pacemaker in C2. You can see the wire in the RA and RV, the lead, then valvular disease with heart failure with heart block. All these things you can try to delineate from this X-ray itself, even if you don't have the history. Yes, so somebody is writing endocarditis. So this is how you have to predict in your head how the case will evolve. So let's see what happens next. So vignette 3, her CT brain was reported as normal, and her GCS drops further with BP of 90/60 and atrial fibrillation ongoing. Your colleague asks you to thrombolize her. What are the contraindications of thrombolysis in this patient? So why, yes, deranged coagulation. Yes, we are thinking in the right direction. So duration is unknown. Your coagulopathy is there, and patient probably is on anticoagulants. You don't know the history. Risk factors of infective endocarditis are present. And how do you treat her atrial fibrillation in this case? So you can use beta blockers or digoxin, amiodarone if acute, and cardioversion you can consider after doing echo and surgical atrial fibrillation ablation after stabilization. So the case evolves, and her husband calls the hospital from abroad and tells you that she has a pacemaker with bioprosthetic aortic valve repair, and she takes apixaban 2.5 milligram BD. Now you get some history. Then you do a TT, transthoracic echo, which shows a normal valve, and ultrasound abdomen shows multiple splenic infarcts. So what would you like to do for her now? You got some history, some extra history. And this is quite the real scenario. Our recall, we were a little bit fumbled, so we have to know all these things. If you are having high supposition of infective endocarditis and your 2D echo is coming normal, you have to do transesophageal echo. They will give you the findings of transesophageal echo also, they can. And then the case evolves, and the TOE revealed a 10 mm vegetation on aortic valve, and blood cultures were sent, which showed growth of gram-positive foci in 3 out of 4 culture cohorts. So what we will do now? And then start to start your antibiotics accordingly. Yes, correct. So you have to start your antibiotics as per your culture sensitivity. You have to control the rate rhythm, and you have to do the cardio surgery consult and GI surgery consult accordingly. And then CTVS consultation was done, and he does not. Your CTVS surgeon doesn't want to operate. Does not want to operate on this patient right now. Why do you think that he's not ready to operate on this patient right now? So you need to know infective endocarditis as a whole case. So there are certain cutoffs when do you operate and certain guidelines. So infective endocarditis surgery is indicated in relapsing infection, that is recurrence of bacteremia after complete course of antibiotics and subsequent negative blood cultures without other identifiable source of infection. And patient is hemiparetic here, also likely a stroke. So these are the points against going for operative intervention for this endocarditis, right? So we are done with the 2A case. Any comments from the from other panelists, Dr. Yas, Dr. Nasrina?
Dr.
Or
Jitendra, Dr. Ayaz, Dr. Nasrina, anything about this CCS?
It's greatly explained everything.
Yeah, I think somebody answering like this, he or she will be getting 10 out of 10 if we'll be just scoring. Yeah. So for this, I just one point. Infective endocarditis previously was not that extensively discussed in critical care, but nowadays in the cardiac critical care, you need to know everything about infective endocarditis. And this is all about like also transesophageal echocardiography. They are also asking now. This is again one new thing. Previously, we used to only like no emphasize on the transthoracic echocardiography. So also they may give you also some of the findings of transesophageal echocardiography. Yeah. Yeah. Thank you.
okay, so we'll go on to the next case, Vinay. So the long case, as I said, would be having the part A and part B. So part B would be another case. This would be the case which would be having the longest time. They will give you around 22 minutes or so. And the other case, which is relatively small, they might give you 17 to 18 minutes. So starting with the first case, Vinay. So you have been called to see a 58-year-old man with history of fever and cough for last 6 days, and his throat is positive for influenza A and is on oseltamivir therapy. He is worsening with increasing tachypnea, febrile, and is having heart rate of 150, BP of 102/66, and requiring oxygen to maintain saturation. He is having a groin rash on the right side, which is gradually increasing over the past couple of days. His biochemistry panel is pH of 7.30, PO2 of 55, PCO2 of 34, bicarb of 13 with base deficit of 12, sodium 144, potassium of 3.6, chloride of 98, and lactate of 4.1, CRP of 24.6. CBC is showing HB of 12 with TLCs of 12,000 and platelet of 0.75. Urea of 19.3, creatinine of 125 millimoles per liter, AST and ALT of 45 and 37 respectively. Then can you again please summarize the case for me? So that would be the opening question usually. So they will give you like 10 minutes or so for the first clinical vignette, because this is the screen where you have to assimilate majority of the information given to you. The clinical vignette, which would be a complex one. Then the biochemistry panel, some labs, the routine labs with the ABG with some imaging. Okay, so what is your, can you summarize the case? Okay, somebody is saying admit to ICU. Okay. So summarizing the case, you have to start with all the initial positive findings. Sepsis, okay, shock. So initial, you have to see the primary thing which the patient has come up with. So keep that also in the very beginning. So there is respiratory distress, respiratory failure, increased oxygen requirement. You have to include everything of that. Okay. I think everybody is tired. Only one person is answering now. I'm also tired. So can you please summarize the case? So let's summarize the case. So yeah, this is a 58-year-old gentleman with influenza A on oseltamivir therapy presented with acute hypoxemic respiratory failure with fever and right groin rash, plus mixed acidosis. Somebody mentioned acidosis with high lactate levels and thrombocytopenia and raised TLCs with raised CRP and acute kidney injury. The creatinine is also increased. So you will get some time. So you have to plan your case. You have to begin with writing your differentials and summarizing your case on the piece of paper. They will allow you. You can ask them for permission. Can I jot down the points? So usually they do allow. And you have to take out all the points. Don't miss out points like acute kidney injuries there. All the positive findings you have to mention in your summary of the case. So discuss the ABG. So ABG will having mixed respiratory with high anion gap, mixed respiratory plus metabolic acidosis with
So
anion gap.
Diksha,
You
I
have to
know
always.
you can just delineate the salient points because
Okay, sir.
it's definitely difficult for you also to jot down everything. So just let
Yes.
them know how the question normally comes in the EDIC 2.
Okay.
Exactly.
So yes. Would you want to say something? Okay. So let's see. So you have to always analyze your ABG. Then what additional diagnostic tests you would like to do for him? So you have to answer all the parameters in terms of the findings of the patient. So you'll do the chest X-ray. There was a groin rash. So you'll do the pus cultures from the rash. You have to send all the blood cultures and stain, sputum, gram stain and culture. So the case evolves and the patient continues to deteriorate with hypotension and rapidly spreading rash with platelets of 0.17. And his pus swab revealed gram-positive organism. So which organism do you suspect in this case? So which organism you suspect here? Okay. So staph aureus, yes. Streptococcus pyogenes. Then accordingly, how you'll treat him, you have to start antibiotics as per your culture sensitivity reports. You have to continue your oseltamivir. You have to give HFNC NIV for hypoxia and intubation if the patient worsens. You have to manage the shock and regular procalcitonin monitoring. Then antibiotics you would like to start. Which antibiotic? So here you have to start clindamycin along with meropenem, and they might ask you the reason why you are starting it for its antitoxin effect. Then what is the mechanism of thrombocytopenia in this case? Why the patient is having low platelet count? Okay. So platelet activation and consumption is there, increased lysis, decreased production, and antibody-mediated destruction, along with platelet scavenging and leukocyte and platelet interaction. So therefore, the patient is having low platelet count here. So here we end with all the clinical case scenarios. So wishing you all the best. I'm glad to recollect all the recalls and present it to you so that it would be beneficial for everyone who is planning to appear for EDIC Part 2 in the upcoming exam. Thanks again for this opportunity to Tapassar, and thank you the Tricks platform.
Thank you, Dr. Diksha. I know you have actually traversed through the critical care completely to let the candidates know about the current trend, and we appreciate. Dr. Neeraj, you want to say something?
Yes, sir. Regarding the choice of antibiotic here, meropenem and clindamycin. So gram-positive coverage, vancomycin.
Dr. Neeraj, you can answer
Oh,
anything till the
okay,
time
okay,
like you can like no explain it that as per my local antibiogram,
okay.
my
Local antibiogram. Yeah.
yeah.
Yes,
See,
yes.
they would
Hmm.
not be taking it so seriously, which
Hmm.
antibiotic as such, but yeah, it has to
Okay,
be
sir.
justified. Yeah,
Okay. Thank you, sir.
yeah. So,
Hmm.
Dr. Diksha, if you stop sharing, then I can just
Yes,
like
sir.
show them 3 slides because we have skipped one CCS and also a few CBS questions. I'm just sharing with you the last thing so that you all can know that the trend for EDIC 2 has changed in recent times, and that I want to show you. Yeah, just 1 second. And all of you, please join our next webinar also, which would be again free before we start our proper course. That day itself, we will be announcing our the course module, the agenda also, how we are going to take the next 4 months of your time. Okay, is my screen visible?
Yes, sir.
Okay, so this is the summary of like the critical care questions that were like asked in the last EDIC part 2. So neurocritical care. So there were questions from the traumatic brain injury, cerebral venous thrombosis, intracerebral hemorrhage, brain death, ICP management, and the examples already you have seen a question with traumatic brain injury plus thiopentone plus potassium shift, CVT with hematoma. What will you do? How you are going to manage? Then brain death on CT angiogram. You have seen that CBS question. Then massive ICH herniation, decompressive craniotomy. Now coming to the infectious disease and sepsis, bacterial meningitis you have seen. Then sepsis with VAB, bloodstream infection, UTI, HLH, very important nowadays. Last time also there were like questions from HLH. This time also HLH. So this is a very upcoming high yield domain. Then dengue case-based questions, post-op sepsis that you have seen in the CCS. Now listeria meningitis that was asked. Then groin rash, influenza, sepsis, HLH in HIV patient. Now renal and CRRT. This is something which has come up like anything in the last 2 exams. We are getting the feedback from the candidates that CRRT prescription, CRRT like the circuits, then the anticoagulation of choice. So all these questions are coming very frequently. And you can see here RRT trigger, dosing, anticoagulation, heparin induced thrombocytopenia. What would be the modality of choice? How you are going to diagnose citrate toxicity, and also how you are going to manage and hit heparin induced thrombocytopenia. Now coming to the cardiovascular, again as Dr. Nasrina has told, it is not like related to atrial fibrillation or AV block. They can ask you in and out about the advanced ECG also. So we have a very good module related to cardiology, and there we would be also again completely revising the important ECGs. Junctional rhythm, bradyarrhythmia was like a very favorite question in current like the exams. Shock phenotypes, monitoring, and the different treatment modalities for the advanced, you can say the dysrhythmia. Post transplant and immunotherapy has again come up very, I would say, drastically in the recent EDIC Part 2 exam, because nowadays it is like one of the subspecialty which is getting attention. Transplant critical care, immunotherapy, CAR T complications, cytokine release syndrome, then what would be the complications of CAR T, then hypophosphatemia. Sometimes there would be sepsis mimics with HLH. So all these things you have to read. Hematology and thrombosis, again, very high yield domain. You will be asked so many questions related to intracerebral hemorrhage. Then there would be something related to patient on warfarin, sometimes like getting complication. Then NOACs, that is one of the favorite question nowadays. So you will be getting this type of questions, and also the monitoring part with the focus, like point of care test, I would say. So how you are going to do it, rotem, and like the you have to be thorough, though we are not using it frequently, but for the exam sake at least you have to understand. So that take and rotem is one of the favorite high yield domain. Now airway and mechanical ventilation, bread and butter of critical care. You are not expected to pass any critical care exam without knowing the airway and mechanical ventilation. This applies to EDIC part 2 also. Winning protocols, bronchospasm during transport, expiratory hold, that question you have seen. Then winning criteria, how we are going to do some maneuvers at the bedside on the ventilator. These are the again the frequently asked question in the recent last two exams. Surgical critical care, then this type of advanced extensive surgery related complications. Then some of the other advanced procedures, recent updates you need to know. Ethics and communication, any CCS, it would be end up in the last clinical vignette with a prognostication or breaking bad news type of thing. End of life family discussion. This is again pertinent to any critical care clinical case scenario discussion. So as a seasoned intensivist, the examiner expect you to handle that part also, and you have to be very thorough with the multidisciplinary team approach for the prognosis talk. Now, toxicology, electrolytes, it would be more related to the Western toxicology, that is the recreational toxins, and something related to environmental hazards like the hypothermia, something related to the bit roadside patient is found unconscious. So how what would be the differential diagnosis? So all these things would be asked. Now, something I want to highlight here, we are having one webinar which is planned next week. I would be informing you in the group, where we would be guiding you what would be the resources that you need to uh, take help from. Apart from, if you are joining our course, definitely it would be having everything. But yes, if you want to have something like what would be the the books, or something like how you should be knowing the tips and tricks, so definitely we will be having a short webinar next week, and that night itself we would be announcing the agenda for our EDIC 2 preparatory course. So with this, I think we have planned till 8:30 p.m. and we are just like 8:35 p.m. at this point of time, Indian Standard Time. So we are dot on time, and just last message I want to just share with you, that be humble, be the craziest person in the the hall, or in your the hospital, to know, to understand the critical care complexities, so that in the real exam hall the examiner would be really surprised and just very happy also inside, to know that yes, the future of critical care is in safe hands like you all. So if any of my colleagues here want to share anything, so we would be happy to take, or else we can call it a day. A lot of effort have been given for making this presentation. I must thank Dr. Ashish Burma, Dr. Diksha Gaur, some Dr. Ayaj. There are many other colleagues. They have also shared questions in our chat box in our previous group. So we remain indebted for sharing this information to the upcoming examinees, and we are there to help you all. So there are certain questions right now. Minimum cutoff period, no, there is no cutoff period. Anyway, if you are preparing well, you will be not waiting for 2 to 3 times also. You will be clearing in the first attempt. Evidence and trials, yes, they would be asking, the questions would not be straightforward that what is the current evidence, rather the question should be framed in that way. So you have to frame your answers based on the current evidence. So last question, I am also clueless how to increase chances on getting a seat opening early or using browsers. Yes, keep one of your friend also, maybe in the other room where you are using your laptop, maybe using a different ID, and wait, open the system beforehand, and that would be like giving you a better chance. Don't disconnect the laptop, because if you will be in the queue, it will be automatically immediately taken you to a that 140 your queue list, waiting list. Don't be patient less, rather just wait. It would automatically again change your this serial. It would be online most probably, though the examination centers they have mentioned in the notification in the website. But as I got the information from the examination committee, so they have actually given responsibility to some of the European centers to take care of the online examination. So maybe 30 candidates, 50 candidates, it would be taken care by the Dublin center. So this would be something like that. I still don't know, but yes, this is something till now we have got information that though it is showing that examination centers, but this is the nodal center. You can take nodal centers and taking control of all these online exams. So don't worry. Anyway, if you are getting the opportunity to visit European centers, take it as a bonus. You will clear the exam and also have some good vacation there. Okay, and bring some chocolates also from the European cities. Okay. Okay. So that's again something very good suggestion. FFICM and Australian Fellowship, we will be definitely thinking about that. So we have lot of things ongoing. Nephrocritical Care Society, some of the very good fellowships we are starting related to nephrocritical care also. Again, we have some very ambitious projects coming up. I am not right now disclosing. Maybe the future of critical care will be benefited by all our efforts. So that I can say for the time being. Okay. So thank you very much, all the faculties, for sparing
Yes, sir.
your Monday evening or Monday afternoon. So maybe this would be the sacrifice which would be counted, and you have already ticked the checklist. So you are 1+ now in your efforts to clear the upcoming EDIC 2. Thank you very much. Wish you all the best.
Thank you, sir.
Thanks, sir. Bye.
Thank you. Thank you, team Bhagyasri and Navneet, for giving your best effort to make this webinar a great success.
Thank you, sir.